Hi, my name is Geraldine. I'm a consultant radiologist at Epsom and Helier, and I'm the AI lead for South West London AI Imaging Group. So we were not successful with the AIDF. Our CFOs never signed it, despite all the hard work. Some of the questions that you posed, we couldn't answer, and that was one of the reasons they would not sign it off. However, we were already piloting a chest X-ray AI tool. So I'm here today to share our experience having deployed the chest X-ray AI tool. These are my conflicts of interest. So just to give you a bit of background very quickly. So who are we? So we put the team together in 2021. South West London is Epsom, St Helier, Kingston, Croydon, and St George's, and we've got an AI lead, we've got a local champion, which is project or site specific, operations lead, research lead, integration lead, member of the executive team to help with getting the nods, information governance lead, IT lead, education and training lead, and we don't have a medical physicist as yet. Just a bit of background, just so that we remind ourselves that the reason we should bring in an AI tool is because there is an existing problem or there is a need for it rather than because we should bring in an AI tool. So our question was, can an AI-enabled pathway improve the NOLCP, the lung cancer pathway? Can we improve the number of patients getting a CT scan? Can we improve the time to getting that CT scan? And can we improve time to getting chest X-ray and CT reports? And very importantly, how do staff feel about introduction of AI? The reason now, why did we do this? To remind ourselves, this is the lung cancer pathway, and essentially, it's recommended that a chest X-ray and CT is obtained within the first 3 days. In 2020, we did an audit which suggested that we were only doing our CTs in 66% of cases within 5 days. So we thought that's not good enough. And that's what made us think, okay, let's bring in a chest X-ray AI tool to try and solve this. So this was our post-deployment strategy. So this was the patient pathway. In black is what used to happen, okay? So the GP refers the patient with possible lung cancer. The patient goes to the hospital, outpatient department, has their chest X-ray done. What used to happen, that chest X-ray used to be reported within 48 hours, and then if it's abnormal, they get a phone call, sometimes from admin, we find out, not even the GP, to make an appointment for a CT scan, which was done within a week. So we felt that by introducing that AI tool, that AI can triage for possible lung cancer, and then we have the radiographers that will call the duty reporting radiologist or the reporting radiographer. They have to call us because it's illegal to just go on autonomous, okay? So this is very important. And we have to issue a report within 30 minutes. If we agree, if the human agrees with the AI output, then we ask the patient if they would like, or we offer a patient a same-day CT scan. So that's that, yeah. And then we report the CT within 48 hours. So this is what our timeline looked like. So we had July 2022, October 2022, December 2022. So starting from the beginning, during those months where we were trying to choose a product, where we were trying to get the governance, those tedious months, we're collecting data prospectively of what normally happens, right, without any of the tools or anything. Then we wanted to introduce 2 months where the triaging is not happening by the AI tool. We introduce the same day CT, and the triaging is happening by a human, i.e. the radiographer. No pressure on the radiographer, not expect them to, it wasn't a performance thing, but what we wanted to do is to separate these 2 new processes for when we collect our data. So the 2 months radiographer triaging, if they see a mass, great, they call us and we get the same day CT. Then after those 2 months, we went live with our AI tool. The second bit, which is also as important, was we wanted to look at the perceptions of the Epsom St Helier radiology staff have of AI. So we wanted to carry out surveys before, during, and after implementation to see if their perceptions have changed or not. That's our AI tool that we're using. It can flag up to 120 pathologies. I'm listing those 14 things over there for a reason. I'll let you know why later on, but that's what it looks like. So I think we finish at 4, and I realize we're short of time.
4:15.
Is it 4:15?
Yeah.
So I thought rather than if we can make this a little bit more interactive, because it would help me as well. So how many of you here have personally already been involved in implementing and deploying an AI tool?
A clinical one.
A clinical one.
Rather than a research. Yeah.
Okay, and how many of you are about to do it? And I presume the rest are keen on having it done, doing it soon, right? So the reason I'm doing this is for those who have done it already, you can probably relate to these questions. And for those who are about to do it, these are questions you are probably going to have to think about, because we have to think about them. So the first one is, how do we ensure that staff have the necessary training to work with these AI tools? This is so important. We get caught up with which tool to use, what we're going to use it for, but how are we going to make sure that all the staff, not just the radiologists, everyone knows about these AI tools, and there's different levels of information of what they need to know. And this is a challenge. Does anyone who have been through this process, who are going to go through this process, have any thoughts on how to go about this? Just there's no right or wrong answers here. Just someone just tell me something. Anyone about to start this, thinking about education?
It's tough. Because depending on the tool, the audience varies. So we're deploying a lung nodule detection thing, and actually it's a very small, it's just chest radiogram crane. We're also doing a fracture detection tool, and we've got all of the A&E trained for that.
Yeah.
And it's completely different approaches.
Isn't it? So it's hard to get that education program put in place. Yeah. So these are all things we need to think of. Should we show the AI outputs to staff outside of radiology? This was a question I had to think about. Do I want the A&E medical wards, surgical wards, knowing what that AI, those 120 pathologies, what are your thoughts for people who are about to deploy this? What are you planning to do, just out of interest? Shout out someone. Go ahead.
I think in general, there's an incredible value for clinical staff to see the point of care stuff. I mean, you know, we've got some radiographs which are refer evaluation. The ITU ones are, and I know your model and our model to be essentially, you know, there are patients on ITU who have had unsuspected pneumothoraces for several days, which the model quite easily picks up on day one. So I very much would support at least a limited digest of findings being given to clinicians.
But I think there's another side of it. We had one new mobile X-ray machine come in that had AI automated in the background, and it was all coming up on PACS and on web PACS, and it was calling a lot of pneumothoraces where there was just folds of a gown or whatever. And there was a risk that somebody in A&E or on a ward was going to stick a chest drain into, because it said, you know, 98% likelihood of pneumothorax on the right. And it was more often than not incorrect. So there was a clinical risk in that. So I mean, I think there are clinical risks that we have to be cognizant of.
Absolutely. Next thing to think about, a lot of you are about to implement this tool. 124 pathologists is a lot of them have the average of 20, I would think. Are you planning, and for those who have done it, are you planning to turn them all on? Because we do have the option to turn a lot off. What are you planning to do, and what is your thought process? Because these are all questions you're going to think about soon.
Yeah.
What do you think, or what can you foresee being the pros and cons of this? Yeah.
I would. It would depend on the use case and the pathway. It's longer because you have to analyze. Well, if it flags this, then what are we doing about it? If it flags this, what are we doing about it? But without walking through that process, you're going in blind in terms of risk or system impacts that you might then create by suddenly flagging up findings.
Do you think there's a difference with an institution that's adopting an AI tool for the very first time, where people are working with an AI tool for the very first time, versus some people who are maybe adopted 3 AI tools already and can. So I'm talking more about the culture of people working with AI tools when, suddenly they're faced with all this. Something to think about, maybe? Yeah.
Obviously, I mean, it depends again on the use case. I mean, if you're wanting to triage the normals, then a tool that flags everything up means that you can be very confident it's normal and it doesn't flag anything up. As long as you have some way of dealing with all the stuff that's flagged up.
Yeah. So this is all really important things to think about. How do we? We had to set up a same-day CT service. I don't know what you're planning to do with your tools, but in terms of a chest X-ray, that was our aim. And the reason I put that there is because what I've learned from this process, that bringing in the AI tool is actually the easier bit. When the AI tool comes in, chances are you're going to bring in also another pathway along the way, another process. And it's very important not to be caught out thinking about the AI tool and then not have the resources and time to focus on that new process that you're about to set up. So in our case, it was a same-day CT service that has nothing to do with the AI. That is opening up slots every day. That's getting radiographers for the first time. And I wonder if there are any radiographers here and what they think about this. For the first time, they're having to tell the patient, hi, we just saw something on a chest X-ray and we'd like to evaluate it more. Would you like a same-day CT? When usually, hopefully, it's the GP that does that. Are there any radiographers here today? How do you feel about that? It's the first time, our team, they weren't so comfortable with that in the beginning.
It depends who you're talking about. If it's somebody who's also trained as a sonographer, they're used to doing that. So it depends what other experience they've got.
Yeah.
But also you're used to telling people if they need additional images. So it's transferring those skills in a way that's acceptable to patients.
Absolutely.
In which case I'd also say we need to involve patients in this. Maybe you want to be told what you want to know.
So the level of expertise of the radiographers now starts coming into play. How do you manage that on a rota? So, and my point is how important open communication and communicating with everyone is going to be so important from the early stages. The other thing that came up with us was how the patient's going to feel to suddenly tell them you've got a CT when they thought they're coming in for a chest X-ray. But then someone else said, well, actually, that's even better for the patient because they don't have to wait for that dreaded phone call for the CT. Again, yeah?
So we just engaged with our GP services and the GP say up front, we offer a same-day CT service just to evaluate all of, So
you do it from beforehand. Perfect.
I think that's expecting that.
And this is, I think, the importance of these discussions, because I think these AI tools were so much in the beginning of this process that we really have to try and collaborate and speak to each other as much as possible, because a lot of us would have gone through mistakes. A lot of us have great things that they're doing. So people who are about to embark on that, we might as well talk as much as we can so we can learn about it and do it together. Last one, how do we ensure that staff accept this tool and work with it? I say that because there was a period when the radiologists thought, sod this, I can't be asked, and they stopped using it. And that's a risk in itself. So what are we going to do to ensure that the users remain engaged and not just park it in the background? Okay? So, very quickly, this is what we did. There's no right or wrong, I would say, because this is what we did. But things to think about. How do we ensure that staff? So what we, the education bit. So what we did, we started having training sessions. We opened up our meetings every 4 months. So we have weekly meetings with the core members, 8 to 10. But every 4 months, we open it up to all the members. We have 40 or 50 people, and it's very, sort of relaxed, kind of trying to chat about things. It's more of an educational experience. That's one. We have an educational lead, but of all of this I feel has been our biggest weakness because it's easy to forget about it. And then should we show the AI outputs to staff outside of radiology? We decided not to, because we were worried it's the first time that we were going to have an AI tool, and we did. First of all, there's the clinical safety things. Let's park that for a second. We did not want to irritate. I did not want to irritate my colleagues, because the moment I irritate them, they're not going to accept it. So So what we thought was going to happen is that I don't know how the tool is going to behave with a pneumothorax, with a patchy airspace. All these pathologies listed, they have different confidence levels. They're all going to be either too sensitive, maybe not sensitive enough. You don't know that till it's working in the real world. So suddenly you start having people calling you that everyone has an opacity, and that's going to be disastrous, right? And these false positives, phone ringing. So we thought, let's do it one step at a time. Let's keep it in the department between us radiologists, so we can detect these oversensitivities or anything that's not working well with the tool, fix it, and then we open it outside of the department. That's what we decide. There's no right or wrong. Where are we? Do we want all 124 pathologies flagged? We didn't want to. We switched off almost all of them. We only have 14 on, which was those that I showed you earlier. So we thought, okay, if we put on the 124 pathology, and again, there's no right or wrong. We spent a lot of time thinking about this. If we turn them all on, we're going to lose focus on what the main aim is. Our main aim is a same-day CT service for people with lung cancer, not the pneumothorax, nothing else. So let's really nail this. Get everyone to have a same-day CT, and then we can open it up later. And not just that, it's a gradual introduction to people, to our colleagues, right? And most of the people are not. We're clearly enthusiastic about this because we're here, but most people aren't. They're just, I think most people roll their eyes when they see me. How do we get same-day CT service? So what we decided then, so this is where I got caught out. I put a lot of effort looking at the AI tools and AI, and then that same day CT service has to work really well. And then I realized we need a separate whole team for that to make sure that's working. Because what we realized was it started off with people being offered the same day CT, and then the radiographers were thinking, oh, we're busy today, we just offered it tomorrow, or we're busy today, and suddenly they were not even offered. It was forgotten, So okay, you need a separate team to keep an eye on this. And then for the radiographers, this was important. And this is highlighting importance that we have open, regular discussions with all stakeholders. They were not comfortable. It's not baking bad news. It's telling someone they have something that needs to be looked at, but they're not comfortable doing that, and I could understand why. So we had quite a few meetings, and they agreed that if they have a template, that they can read from, not the experienced radiographers, those were fine, but you never know. There are less experienced on new people, bank. We gave them a template, and they were happy with that, and they just sort of read it until they don't read it and they know it. So they were happy with that. So before I move on, anyone strongly disagrees with anything? There's no right or wrong here. There's no, or would have done something differently. I agree. It's about the use case. I think that's the most important thing. So this is not what works for us. It's going to work for you. It's all about that use case. So just very quickly, in case you were curious, I don't know. So we've collected data over a year, but this is our data up to month 4. We're going to publish our 1-year data soon, but to give you an idea. So where are we? So CT follow-up same day went from 4% to 19% when there was that radiographer triaging, to 32% at month 4 for same day CT. And then within 3 days went from 42% to 44% to 62%. The average time from chest X-ray exam to CT exam went down by half, almost, at 4.8 to 2.5. Now, in the ideal world, that's 100%, right? That same day CT. That had nothing to do with the AI tool, in my opinion. That's got to do with that same day CT pathway, okay? So that's what we've been trying to improve. Very quickly, in case you're curious, these were our survey results. So as to remind you, we did one before, during, and after implementation at month 6. What's interesting, so we asked loads of questions. There's a lot of information that came back, but these are what we felt was most, relevant and important. So we asked, one of the things we asked is which one of the following positive factors do you think introducing an AI tool for chest X-ray will bring? So orange is before, green is during, black is after implementation, okay? If you can look up on top there, you can see that most people thought this was going to be a time-saving tool, okay? And then if you look down, you will see that in the end, people realize actually maybe not a time-saving tool, but it allows patients to get follow-up care faster. And I think that's more accurate with our use case. And then we asked, which one of the following drawbacks do you think introducing an AI tool for chest X-ray will bring to the department? So again, orange before, green during, black after. If you look at before, people were worried about cost, but then when they were in that process, they realized that actually this is really increasing our workload. It's not saving us time. And that was, again, because of that same day CT. They were thinking suddenly the radiographers have to do extra things. Suddenly we're opening a same day CT slot, the radiologist having to report within 30 minutes. So that was them being quite annoyed at that stage. And then at month 6, you can see that they sort of everyone's calming down a bit. And then it came out that mostly there were no drawbacks and went back to cost, that this was going to increase cost. And then at the bottom, interestingly, you can see a shift, black again after, shift to the right, which means more favorable opinion about the AI. The first one was we asked them if it was their own chest X-ray, would they want an AI tool being used, and eventually it's all shifted to the right, which means yes, actually strongly agree. And the second was, how do you think patients find their experience having a chest X-ray now compared to before? And again, shift to the right, significantly better. So 10 minutes to go. So you reach that point, and then a whole barrage of next challenges come along.
5 minutes.
5 minutes
of questions.
Yeah. Next barrage of challenges, and this is very important. I don't know the answer to this. This is tough. Monitoring. Do any of the specific pathologies need the sensitivity level adjusting? Okay. These are questions we ask ourselves, and you're most likely going to ask yourselves. Are more patients going to CT? Are there many more false positives? Are more patients being CT? Is there automation bias? How are we going to monitor this, and how often? And how do we keep the momentum going? You feel that there's this sort of post-hype neglect, you know, yeah, we've got the AI tool, and then suddenly everyone's forgotten about it. We can't do that. We've got to keep that momentum going. And big challenge for us here, in view of that AIDF, how we build a good business case. This is an interesting slide to give you an example of why it's important to keep our eye on findings. You see at the bottom there, focal space opacity, we've realized that it was overcalling that. You change, so you'd have to most likely overcalling, most likely causing the false positives. So you'd have to change the sensitivity for it, possibly, to just adjust it. So things like that, you've got to keep an eye on, okay? Now, my last 2 slides. So I think we all agree AI tools need monitoring. This is part of the education bit as well. I think it's you probably all know about this, but it's important we keep reminding ourselves. I'm no expert at all, but I think these are things that us as clinicians need to know. There's bias and quality. We know that the training data may not be accurate. We know that the data may be biased and not representative to the population that you're serving. Human and AI interaction. Are the humans collaborating with that AI? Because poor use of that AI is a risk within itself. Adverse events, we know that there can be misleading outputs which may lead to harm. Performance degradation, again, we know that these AI tools can change performance over time with new cases and as the technology evolves. Generalizability, again, these tools may behave very differently in different geographies, different population, and there's regulatory compliance. But last, very important, okay, we know all that, but what do we do? We have lack of human resources. Thing takes time. I mean, we've got Susie, who's our chief research investigator. I mean, we're few of us, you know, how many, this takes a lot of time. It's time consuming. It's costly, because ideally we have a monitoring tool to do this, but it costs money. Post-hype neglect, are we going to bring it in and forget about it and just let it run in the background? Big risk, I think. The black box, these tools, are they transparent enough so that we can easily know if something is going on? And also, there are about over 200, I think, AI imaging tools right now, but about only 3 or 4, you would know how many competition there is, but only 3 or 4 monitoring tools around. So not very many, and they're important, and a lot of them are quite expensive. And lack of real-world experience with AI tools. Right now, we're not maybe that worried because we have 1 or 2 tools. I, for example, work with a TMC, teleradiology company. We've got 12 AI tools, and it starts getting tricky then because you've got many tools. How do you navigate that? So we've got to focus on this now. And these are my lessons learned. You can read through them. I don't need to go through them. Just maybe one thing, focus group, which I didn't mention, very important, I think, to have a focus group of people who you trust that are users, both when you're in shadow mode before and keeping them there after you go live for, say, 2 months. The longer you have them there, the better. So they can keep letting you know how they're getting on, and consider off mode periods, because that will help the radiologists not get the automation bias. And you tell them that we're switching it off for 2 weeks, and then you can even from a research point of view see if there is a difference, but they know, so then they have to wake up again.
Yeah. Well,
Okay, that's that.
fantastic. Thank you so much.